Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
Intro question. Okay, so do you want to go for it, Mike? I hit the record button, so we're live.
My big question, I guess, was any new pop culture consumption, music, movies, books, anything? Dealer's choice.
Ooh. Lauren and I have said for like a month now we're gonna pick a day of the week to like read a book. We still haven't done that in the evenings. That's something we want to do. Maybe when Lauren's a full on attending, we'll finally have the energy for that. We do want to start reading. But for consumption of TV, which we do very regularly, we just finished the new Love is Blind season. Yes, listeners, we do we do watch that. It's very entertaining. I blame Lauren. She got me hooked. Yeah, I'd say that's kind of the first one that comes to mind for what we watched and really enjoyed. But what about you, Ben?
Well, Love is Blind Brazil is very popular in this household. A good way to learn Portuguese for me. A lot of simple sentences and common words, so it's good. And yeah, we're watching The Pit also, which I know we're like years behind on that, but just finally got the logins, got the paying for HBO. So a lot of good stuff on there, but we started there. It's kind of weird to come home from work and then watch a relatively accurate medical show.
It's intense. We watched season one. I know there's active episodes out now. We
Yeah.
gotta catch up.
I think
Um,
we're the last episode of season one, so we have to see.
got
It's
you.
good. I
Oh,
like it. I mean, there's some, it's still dramatic. It's a television show, but it's pretty good.
yeah, it's very similar to real life, honestly.
Yeah.
I really think
Yeah.
they capture things pretty well.
And no one's getting
Uh,
shot in the OR, so
it does make me feel for our ED colleagues. They really, yeah. Shout out to any ED listeners, EM listeners. Thank you for what you do, for sure.
yes. Yes, it definitely justifies the CT scans.
Are we doing an ED case today?
Well, it starts in the ED, I suppose, as most of our cases probably do. But no, not necessarily. So you want me to jump into it?
Yeah, let's do it.
Okay. So this is a 65-year-old guy. He's pretty ill chronically. He has poorly controlled type 2 diabetes, CKD3, which is stable proteinuric, most likely from diabetes. No biopsy though. Gout, which is really debilitating, and he's actually on chronic pred. Frequent flares with prednisone used for those flares, probably 3 or 4 times a year. Had a kind of chart history of a stroke with vision loss that's seemingly resolved. There's not much in the chart about the specifics there. It was like a decade ago. AFib, and then pretty severe non-ischemic cardiomyopathy, 20% AICD, multiple hospitalizations in the past year with heart failure, and no etiology, no obvious cause for it. He's had a ischemic workup multiple times, which have always been negative, like very mild, non-obstructing disease. Um, so he was here about a month ago in the emergency department for a gout flare, classic sort of his usual issues and the wrist. Got prednisone, sort of partially improved but still present, and that's sort of what's gone on in the last month. You're now seeing him because of sudden painless vision loss in the right eye. And I guess I'll give you some history there and kind of let you know sort of the events leading up to this. So, basically was in his usual state of health other than the gout flare until about 5 days ago when he started to notice that in the right eye, felt like he was kind of looking through, he uses the quote, gray fog, and actually sort of realized that he lost basically all of his color vision in that right eye. So he closed his left eye, and he said the whole world is like black and white. That has progressively worsened over the last 5 days until the point now where it's, he can barely see out of it. It's very gray. He says it's kind of like looking at like a fuzzy TV screen, like the old bulb television screens, that static. Um, and it's, he sort of says blurry, but he's not sure exactly how to describe it. And again, yeah, it hasn't improved at any point. It got worse, and so finally he decided on day 5 to come in because he's afraid of losing his vision, of course. I'll stop there and just see what questions you might have for me or the patient, and then I can give you sort of the next steps here.
Yeah, certainly very concerning story. To be honest, I'm a PGY 5, almost 6 now. I don't know if I'm doing my math right. I actually haven't kind of worked up acute kind of persistent vision loss before, but I think we've all taken enough board exam questions to kind of know the can't miss entities for acute vision loss. How does one get vision loss? I guess we can remind ourselves that, light has to pass through our cornea, go through the inside of the globe. It gets refracted at some point, like through the lens, hit the back of the retina, and then kind of shoots back through the optic nerve and eventually hits your cortex after crossing over. That's kind of like the visual pathway for dummies from an internist perspective, kind of approach to vision loss. So, when you consider what processes can kind of come on quickly and basically akin to a stroke, you do worry about kind of vascular occlusion processes leading to vision loss. Again, this is basically just a stroke. So if you have something like a central retinal artery occlusion, your vascular supply to your retina will just be suddenly completely impaired. So that can lead to sudden vision loss, and that'll be painless, just like as if you have a stroke where you can't move an arm. It should be like painless. Your brain doesn't really have like pain fibers to feel that. What you're instead experiencing is kind of like the neurological consequence of that ischemia. So that's like one way I would say you can get kind of like hyperacute onset, in this case, vision loss. I think another way is you can have, of course, like ischemia to the optic nerve itself. So we've talked about like giant cell arteritis doing this, not in terms of affecting the optic nerve, but affecting the muscles that can cause diplopia. But there is a vascular supply to the optic nerve too, so you can have like arteritic in the form of giant cell arteritis, ischemia of the optic nerve. But in a patient who has a lot of cardiovascular risk factors, which this guy pretty much has everyone in the book, you can also just have ischemia of the optic nerve from non-arteritic causes. So just like, again, cardioembolism to the arteries feeding the optic nerve. So I would say in somebody who has multiple risk factors for cardioembolism, he has an impaired LVEF. He could have basically stasis around the left ventricular wall that predisposes to an LV thrombus formation that can cause embolism. Atrial fibrillation in itself, of course, can cause cardioembolism. I forget if we heard if he's on anticoagulation or not, kind of like decreases the risk of both of those things. He could certainly, irrespective of all that, just have really, really trashed carotid arteries and atherosclerosis and be at risk of basically like vessel to vessel embolism. So, regardless of kind of like where it came from, I think that's kind of the most urgent cause. Of course, this is like 5 days later, so we're like kind of out of the traditional stroke window. But I would basically be treating this as an ischemic stroke until proven otherwise. We would want to do like vessel imaging to see if there's some sort of occlusion of the blood vessels leading to these sorts of things. I'll just say a couple of other like broader comments on vision loss, because it's always helpful to kind of define the problem a little bit further. It's curious that it's unilateral. You told us that very, very clearly, like covers the left eye, I think you said, and the right eye completely goes down, but not vice versa. So in terms of just like pathophysiologic things that are more likely to do unilateral versus bilateral, you know, things that are kind of like anterior in the eye, so like corneal disease, cataracts. It's kind of hard to get those issues bilaterally acutely, right? So I'm thinking less of kind of like the anterior structures of the eye and some sort of like strategic way for only one of the eyes to kind of be affected. So I wouldn't be surprised if on the exam, for example, the more anterior the structure is, if it's deranged, the more you're going to kind of see externally on exam. So like I won't be surprised if we like don't see a red eye. The conjunctiva looks completely okay because I think we're kind of talking about something more posterior in the eye kind of being at play. So with that in mind, I'm not going to be doing this. I'm going to be consulting ophthalmology to look through the pupil and see if we can look at the retina and see if we see any abnormalities that may clue us in to what's driving the sudden painless vision loss. Just off of the top of my head, if the central retinal artery is occluded, perhaps the whole retina would look very pale, like some sort of like color change. I do remember, um, sorry, I'm laughing because my dog looks hilarious in the background of the screen now. Um, if the if there's like a central retinal vein occlusion, which I haven't talked about, that can cause, I remember from our board exams, like a very, very profound retinal appearance. I think it's like thunder and lightning or some blood and thunder, some ridiculous term like that. Maybe we'll see that. Yeah, so I think to summarize kind of my initial thoughts for the case, can't miss is some sort of like ischemic process. What fits a painless acuity, very acute onset, and unilateral, and risk factors for it. And then perhaps the quickest thing we can do is have someone look at the retina with an ophtho console and then do brain imaging. But yeah, again, approach for dummies. What happened next, Mike?
No, I don't think that's a dummy approach. I think that's exactly right. Yeah, it's kind of stroke until proven otherwise, right? And then kind of thinking through that. So yeah, I can kind of give you, I think all the things you had asked for. So he, sort of quickly is identified as a, sort of a stroke rule out or a stroke admission, and basically gets the imaging. What I'll tell you first is just some exam stuff. So he's stable, not even hypertensive, no vital changes at all, not febrile. He looks better in person than his chart makes him sound. He's ANO times 4. Really no concerns in terms of comprehension. He's not dysarthric. His cranial nerve exam is notable for sort of has a mild loss of the left nasolabial fold, sort of a facial droop there, which his wife said developed about a year ago. I never sought treatment or diagnosis, so that's not necessarily new. He has a right a right afferent pupillary defect. And then, I'll just say we took a look, our best we could. Looks a little pale on the right side, as far as we can tell in the back of the eye with our cheap Welsh Allen. And then really no other strength deficits. He has normal gait, and just in terms of outside of the neuro exam, he's cardiopulmonary exam is actually pretty benign. His lungs are actually clear. No lower extremity edema. Abdomen is not without abnormality. So really, we sort of full exam is relatively normal, and then his neuro exam is the things I just mentioned. He does get a CT of the head non-con at first, which is negative. He gets a CTA of the head and neck. He has calcific atherosclerotic disease in the intracranial ICA, vertebral arteries, but nothing sort of looks super stenotic, no aneurysms, no large vessel occlusions. And that's sort of he actually there apparently I actually don't see it here, but for some reason there was mention of the carotids looking more stenotic than expected on the CTA, and so he got a Doppler, which also was but not significant stenosis, and I think those are sort of the big images. He can't get an MRI because he actually has some shrapnel, and so he's unable, unfortunately, to get that best imaging study. And yeah, give you some other information, I suppose, just the basic labs. So, Chem 7 doesn't show anything out of the ordinary other than his baseline CKD. So, 172 is his creatinine, and that's where it lives. He has a kind of a mild alk phos elevation, 167. That's chronic for him and at baseline. INR is 1.3. He is on apixaban, which can sometimes unreliably change that. Um, and Yeah, I think I'll stop there and see. Neurology sees the patient. Actually, let me give you the retinal exam without just me. So neurology sees the patient, sort of agrees with the exam, not within the stroke window, sort of do secondary stroke workup, and try to figure out what might be going on. They do think that cardioembolic may be still likely, but it's just too small to be seen on the imaging. And then ophthalmology sees the patient, and they mention, retina is white centrally throughout posterior pole with heme extending mid peripherally. So basically, the center is white, and then kind of around it, there's some what looks like basically like hemosiderosis. It looks like some blood leaked out, kind of in the periphery of the eye. And they're initially concerned for branch retinal artery occlusion, and then the imaging findings, sort of what they are, then they become a little bit more confused, and you know have us admit them to medicine and see if we can figure anything else out. Now I will stop.
Okay, so just so I'm interpreting that last part correctly, um, they think it was some sort of retinal artery side branch occlusion because we do hear that there were some like color changes going on. Is that kind of their final impression based off the retinal exam?
That's correct. They sort of say it is a little bit non-specific, like it's not really classic for anything, but it does look like the problem appears to be the retina. Like that's where the money is, and it explains his symptoms, like especially the color vision loss too, right? With like the center kind of knocked out. And then, yeah, so basically like ischemic versus inflammatory etiology is what's sort of elicited.
Got it. Okay. So we're basically trying to solve ischemia. So this did end up kind of localizing to a structure in the system that's like painless when it infarcts, like we said earlier. So like strokes don't produce pain, but this is basically some sort of like stroke of the retina. So yeah, I think we could separate this out into kind of like what Opto said, like just kind of like bland ischemia versus like inflammatory ischemia. Basically giant cell arteritis, like anybody over the age of 50 who has like acute vision loss, you just have to ask the question, is this someone who you should treat like urgently for giant cell arteritis? So like the textbook says that giant cell arteritis causes painless vision loss. Because of the reason we just said, like these things don't hurt. But you do want to just ask the question of the patient, have they been having symptoms similar to that other patient that you presented us a while back? Tenderness when they're putting a hat on, when they're combing their hair, new headache description, when they're eating, are they having any jaw pain that's new? You kind of have to distinguish that from TMJ. Any fevers that are unexplained, any unexplained tachycardia, weight loss, basically symptoms of kind of an untreated vasculitis, which is what giant cell arteritis is. It's kind of like this large to medium vessel sort of process where the large vessel stuff can cause aortitis, but the medium vessel stuff can cause like this temporal arteritis. And then downstream of all of that, that can cause ischemia of a lot of different structures. So, yeah, I think we kind of have to prove to ourselves it's not that. This person's been exposed to steroids a lot. So, this is not their first rodeo in terms of if there's any concern at all. You could probably just put them back on high dose steroids while we think about that a little bit harder. Maybe wait for a temporal artery biopsy if any of that kind of review systems I just asked does end up getting elicited. But this guy has really good reasons to have just like bland ischemia. Just like, again, he's so many risk factors for cardioembolism. Um, Even without the MRI, I would say that would confirm that this is some sort of like occlusion process. I would say we really again have to prove to ourselves that there's not some sort of source of embolism in this case, the pretest probability is just so high that I need a lot to kind of make myself say this is not cardioembolism. So we've exonerated the carotids. They sound pretty low risk based off of the velocities that you gave us, and also the CT you gave us. I think we need an echo to start. So I think we need an echo to see if there's an LV thrombus, a left atrial thrombus. And of course, you can have embolism not from thrombus, but something else, like basically vegetation. Is this somebody who's had any sort of um, unexplained inflammatory symptoms? Could mimic giant cell arteritis. Could be a source of infection and a vegetation. And if that's the case at all, again, there's a negative echo, the better test for something like an aortic valve vegetation would actually be a TEE, like a transesophageal echocardiogram. So you would want to even kind of take it a step further and say, can we, with the highest confidence test, the TEE, rule this out if that's something, if we're in a situation where nothing else has been identified. So yeah, I'd probably start with the echo, get the history, and kind of go from there. Because I think once we have kind of the review systems, that will kind of guide how high our pretest probability should be for some of these things like giant cell arteritis and infective endocarditis. And then we can kind of do the full test selection from there.
Fantastic. Yeah, that's sort of where we went next actually as well. So he does get an echo, just a transthoracic, and redemonstrates his severe, cardiomyopathy in terms of, his EF's 20%, no signs of intraventricular thrombus. What has changed a little bit is that the aortic root is now mildly dilated. He has mild aortic regurg, which was not present on the echo report. You go and review the echo with the cardiology echo folks, and they say, no, this is new. It's not severe, but it's definitely new. And then, he has sort of really dilated left atrium, right atrium, some pulmonary hypertension that probably is, group two. And that doesn't look any different than before. That looks about the same. Had you asked for anything else? I apologize. That was the
Yeah.
echo finding.
Yeah, what about kind of any symptoms that could go for vasculitis, infection, anything like that on a review? So symptoms, it was really just this eye stuff.
Yeah, I mean, he actually is most still kind of the most obvious complaint is this right wrist pain, which has existed sort of for a month. To him, it feels very similar with prior gout flares. It's somewhat better on the prednisone that he's tapering down from. He's still on, but tapering down from. But he's it's still present. And on exam, I mean, it is. I guess I forgot to mention that. So does have a swollen red wrist, which he says looks better than before. Um, Again, it's kind of a joint that he's had it in before, and this is a common problem for him. So that's what he's
Mm.
saying. Otherwise, not mentioning any jaw claudication, headaches, pain with hats or combs, no proximal weakness, anything
Okay.
like that.
Okay, and maybe I'm chasing nothing here, Mike, but it sounds like he has like a long-standing history of gout. Surely at some point he's had like arthrocentesis, but are there any weird parts of the story with the wrist recently, like more flares through prednisone, kind of like refractory through prednisone? Any new taps recently to confirm that there's not something else going on in the wrist?
Yeah, it's a good question. We actually tapped it, and it shows gout. I think it's let me actually have the reading here. So it's let's see. 33,000 WBCs, 31,000 PMNs, and synovial fluid consistent with, he's got gout crystals, he has intracellular gout crystals. It's felt to be consistent with gout. They do send cultures, nothing grows from those cultures. There's nothing on the gram stain except for the gout crystals.
Got it. Okay. I asked because if you have uncontrolled endocarditis, that can cause like seeding of joints and kind of multifocal septic arthritis. So, okay, sounds like that's not the case. When you see intracellular crystals on the microscopy that's very, very specific for active gout, not like chronic gout crystals that are floating around. So the fact that you see the macrophages like eating the crystals, that means that it's very, very likely just an actual acute gout flare. You're not just kind of seeing a bystander process. Okay, there's really, it sounds like no signal for anything else then. So I think in the absence of any other concerning GCA findings, with the risk factors for cardioembolism, I'd probably just be talking to rheumatology and ophthalmology about GCA without any other symptoms, just because it's so much of a disease you don't want to miss when you can just give steroids and like they can get magically better because like very, very high, um, highly effective treatment, low morbidity treatment. So I think if anybody has a whiff of concern in that sort of direction, even without any kind of like secondary supporting characteristics, we would probably just want to give steroids until we sort it out and we do the full workup, doing the temporal artery biopsy or doing a duplex ultrasound of the temporal artery. So I'd be getting opinions on that. But I think at the same time, just because again, he has so many risk factors for cardioembolism, it's not unreasonable here to like get a TEE, even without like endocarditis, just looking for some sort of vegetation. I don't know if there's something in that area of the new aortic root dilatation, or maybe there's like a thrombus hanging out there, or you could like better visualize it with the TEE. But we kind of have to look for a source for that because this was basically a stroke. And again, pretest probably just so high that we really need a better test to kind of characterize that. So I'd probably be doing those both at once. But what happened next?
Yes, very. It gets interesting. Oh, it's already interesting. Gets more interesting, I suppose. So, ESR is 100, CRP is 105, which is sort of concerning in isolation, but harder to interpret when you consider this guy as an active gout flare. You can see that the values were lower during, they were obtained a couple months ago, and they were lower at that time, but hard to say. Um, Rheumatology does see the patient, and they actually feel like GCA is pretty unlikely. They do an ultrasound at the bedside of the temporal arteries, excuse me, and they don't see any signs of thickening of the arteries, of the walls, which I think I learned is sort of relatively sensitive and specific, that test. Obviously not as much so as the temporal artery biopsy, but they feel pretty strongly that this is not GCA. Um, that being said, his gout's not better. And so they do actually give him like a mega dose of steroids, and they're kind of like, it's not quite GCA dose, but like, he's going to get more steroids either way. Um, Interestingly, he does actually have some improvement in his vision after the steroid dose is increased. And rheumatology is like, all right, whatever, we'll see him in a week. Neurology feels the same, and ophthalmology also says we'll see him in a week. And the patient really wants to go, and so with that sort of within 7-day follow up, we're like, okay, give him sort of return precautions. He's already on apixaban, he's already on aspirin, from his prior stroke. So he's had a lot of secondary prevention already on board, sent with an event monitor. Although we already know he has AFib and he's in AFib during the presentation. So that's sort of where things end with that hospitalization. He's then sent back 7 days later from the ophthalmology clinic, actually. So they've done a repeat exam, and his vision's worsening again. And so they did a repeat exam anyway. And now he has hypo, and I'm going to interpret, I didn't know what any of this meant either. So hypopigmented placoid lesions in the posterior pole, superior retina with associated intraretinal hemorrhage, um, and pallor as well. And sort of still concerning for ischemic versus inflammatory, but now they're much more concerned for inflammatory because they feel that ischemic has sort of been ruled out, or their suspicion's much lower. And they don't feel that this is sequelae of the prior insult. They feel like this is something that's evolving, and unexpected. So he's sent in again for basically workup for inflammatory retinitis in the right eye.
Wow, really interesting. And then, yeah, you kind of use the word like inflammatory retinitis. I'm trying to understand kind of like what the underlying kind of mechanism and like descriptor of the process is. So is it really like retinitis, or is it kind of like multifocal? Like there are these small kind of like arteries that are getting inflamed, they think. Like how did you kind of like interpret that? Just because I want to solve the problem kind of correctly.
Yeah, I think that like the retinal pallor kind of that we see that with ischemic etiologies as a sort of you just lose the blood flow. But I think that because they're seeing this intrarenal, excuse me, intrarenal, intraretinal hemorrhage kind of mixed with it, they feel like there's some like inflammatory process there that's like ongoing and not related to an ischemic infarct. So basically,
Okay.
something inflammatory is happening in the retina.
Okay, interesting. That kind of sounds like kind of the palpable purpura kind of equivalence within the retina. Like you have a blood vessel that's inflamed and then it kind of bursts open and hemorrhages. It sounds like that's kind of what you're seeing inside of the eye. So, yeah, I mean, based off what you're saying about like the test characteristics of the temporal artery ultrasound and kind of rheumatology suspicion, and also kind of the failure of treatment of the high dose steroids. This makes, I think, GCA a little bit less likely. I don't know if they're like refractory GCAs where you do need to go like to the I forget if it's tocilizumab. I think it's like IL-6 inhibitor. I'm gonna say this makes GCA less likely, and now I'm just gonna be kind of making stuff up and pulling stuff out from way, way long ago. I'm like, are there, not autoimmune diseases that can do this, but some infections that I can recall that can do this? Because anytime you see something kind of get better with steroids and then get worse, it does make you wonder if there's an underlying infection. There are some weird things, like I think Bartonella can cause retinitis. So does this guy have any dogs or cats and any like recent wounds on the legs that have been licked by the said dogs or cats? Because that could be an initial presentation of Bartonella for sure. Maybe it's even like driving the gout flare for some weird reason. I don't remember if syphilis can do this, but it's certainly worth looking up. But no, at this point, Mike, I feel like I just have like a lot of reading to do to kind of look for a checklist of infections that can do this. Ask him for risk factors for those things because I can't think of anything other than GCA that can do this. So this is kind of like the crux of the case for me, and I'm curious to learn the case conclusion and if I'm missing anything else beyond those categories.
Yeah, no, you're taking us right there. I was just going to give you kind of a bunch of labs, not every single one, not the ones that might reveal the diagnosis, but I wanted to sort of give you a smattering of labs here and just see if anything jumps out to you at all, sort of a dump. So he has a TSH that's 8.8, but a T4 is normal. Hep C is non-reactive. He has an OncoSent that's negative. He has an HIV that's sent that's negative, CMV that's sent that's negative. He has a Bartonella IgG, which is positive, but IgM is negative. Toxoplasma is also sent IgG, IgM, both negative. And he actually has a positive anticardiolipin antibody, both IgG and IgM, negative beta 2 glycoprotein, negative lupus anticoagulant, positive ANA at 1 to 320, with a mildly positive anti-double stranded and mildly positive anti-RNP. These are sort of like just above the upper limit of normal, but still being marked as positive. Positive rheumatoid factor as well, which is about twice the upper limit of normal. Anti-CCP, no Lyme. Cryoglobulins were sent as well, which are negative. I think those are the big things that were sent. Yeah,
Any C3 or C4 scent like the complements?
those were not sent, no.
Okay, got it. Got it. Yeah, this is curious. I mean, this generates some hypotheses. I don't know if it's going to actually get me to the final answer, but it does stir some thoughts. We talked from the very beginning about kind of risk factors for cardioembolism in this patient, but then kind of moving beyond that and talking about kind of like inflammatory embolism for endocarditis. Anytime you see many autoantibodies you do want to make sure there's not some sort of uncontrolled infection in the body. And endocarditis is like a very prototypical example of something that can cause multiple autoantibodies to be positive. So there are like many, many case reports of endocarditis causing the beta 2 glycoproteins, like the antiphospholipid antibodies you mentioned, to be positive, the ANA to be positive, rheumatoid factor, actually, very much the can't miss diagnosis for that is endocarditis and HCV. So that almost like drags me back to square one. Like, is this someone who has occult endocarditis? And this is the very, very first presentation of that. Funnily enough, the RLR podcast has a case that follows this arc exactly, where it was like actually it was a hemorrhagic stroke as the presentation, like from a mycotic aneurysm of endocarditis. So the diagnostic journey was like stroke, and then this person I think didn't have many kind of like symptoms of endocarditis, but they actually did end up having that. So it was this backwards phenomenon where usually people come in with endocarditis. It's like fevers, joint pains, rash, they feel really, really sick. So it's like very obvious they have endocarditis. But in a case like this, it would kind of be like the other example I just mentioned, where nobody's really thinking about it, but you kind of should think about it if we have no other explanation for something that could very much be this like embolic process. And now we're seeing some signal in the labs that maybe there's something in terms of an uncontrolled infection here. Because like when you ask what would a patient with lupus look like with the ANA positive, the double-stranded DNA, the RNP, are there like cytopenias? Do they have chronic polyarticular joint pain, malar rash? So you're kind of like running the usual lupus script. And if you don't see that, they're kind of meaningless. And it makes you wonder, is there something else making those antibodies be positive? So speaking to the relevance of the antiphospholipid antibodies, initial presentations for APLS can be very weird. Like they can start very focal in terms of thrombosis before they really take off and become multifocal. So this guy would be presenting super duper early if this was APLS. And yeah, I'm not hearing that there's thrombocytopenia. I think I didn't hear about that. And yeah, it's just so restricted that I kind of wouldn't be thinking about that too hard. Any sort of inflammatory process also can drive the beta 2 glycoprotein values to be up. So that's actually the basis for retesting for antiphospholipid syndrome. You want to kind of like get them out of the acute illness window whenever you're testing them up front. And then in 12 weeks, you see them in clinic, you want to resend those antibodies because if they go away, then they were likely clinically insignificant and they were just related to acute inflammation. Whereas if they stay positive and they have weird unexplained thrombotic stuff, like this eye disease, and then maybe you see like some new purpuric lesions elsewhere, then they are clinically significant. So it's very hard to like make sense of those antibodies at this time. But I would just say on the whole, they don't like kind of elegantly match one thing, and it makes me worried about something else. So kind of going back to square one with the TEE, I don't think you mentioned blood cultures were sent. Of course, we can entertain culture negative endocarditis if we see something, but blood culture is very low hanging fruit in this case and something to kind of start with.
Awesome. So the next sort of like aliquot will reveal the answer. So I actually wanted to just pose a question. Um, so, you have all of this. I was wondering if so this guy has sort of severe cardiomyopathy that's, it's been a problem for some time. Non-ischemic, I mean, it's not had probably doesn't have the workup that it deserves, but he's had the ischemic workup that's been negative twice. And now he has this echo finding of like some new aortic root dilation and this worsening AR. It's mild, both are mild, but wasn't there before. I'm just wondering if that, if you can tie like the things you've been talking to within the filter of that. We don't have a TEE for this. I can tell you the blood cultures are negative. Um, but yeah, I'm just wondering if there's any cross reactivity between that finding and then the other thing you're thinking of.
Yeah, very different filter from what I was thinking of. For non-ischemic cardiomyopathy, it's such a broad differential diagnosis that the way I kind of think about cardiomyopathy is kind of with a first pass, second pass, third pass kind of uh, framework, kind of starting with common things and then moving on to less common things, but things that are very easily catchable with the history. So you already told us it's not ischemic. That's like base rate. That's first pass for cardiomyopathy. For second pass for cardiomyopathy, I think of three T's, so toxins, any medications. Sounds like this patient's not on any of that. Travel, any Chagas at play. And third T is tachyarrhythmia. Obviously not the case for this guy. So you move on from that. You think of high output heart failure. It doesn't sound like the case for this guy. Nothing's really fitting that. And then really like past that, you are kind of at like infiltrative cardiomyopathies, and you can stratify that into more like subacute, acute diseases and also into more chronic diseases. So the more chronic cardiomyopathies are like the true chronic infiltrative ones are like true infiltrative diseases. So like AL amyloidosis is pretty like slow, I would say. And of course, if we're talking about connecting all of the dots here, I don't think AL amyloidosis really fits that. Hemochromatosis fits in here, also doesn't fit the illness script for that. So really more like the acute subacute side of things. It's really more of these like inflammatory myocarditis sort of diseases. So there myocarditis has its own, it's kind of like a pathologic descriptor and has like its own kind of extensive differential diagnosis. But I would say if you're trying to synthesize everything in this case, I mean, lupus myocarditis is a thing, so that could be explanatory. Systemic sclerosis can also cause myocarditis, but this guy doesn't really have kind of the other features, I would say, of systemic sclerosis, like skin thickening, Raynaud's, GI dysmotility, and stuff like that. And lymphomas infiltrating the heart can do it. So I would say, kind of running that entire list, I would be most curious about some sort of like myocarditis kind of disease causing inflammation inside of the heart, potentially seeping into the aorta, like causing aortitis. But the question is like how you would tie in the eye stuff, like you're saying. So like, is this just a different vessel manifestation? Like, is this primary process causing vasculitis of the large vessels and the small vessels, or is this more like the heart goes down, so you have the cardioembolism? And you're telling me there's no TE, so I think it's time to throw that hypothesis out of the way. So no, I mean, in terms of vasculitis, we categorize that, small, medium, large, and really the only kind of like pan vasculitis you talk about, like affecting all of them, is like Behçet's disease. But that's more like you have oral ulcers, joint pains, you have pathergy, like whenever you get some sort of physical injury in the arm, it kind of like ulcerates and you get like the pyoderma there. I'm not really hearing that for this. So yeah, I have a lot of questions, Mike, and I don't think I have anything kind of insightful to share at the end here other than just kind of like shotgun hypotheses. So very curious what your team came up with. It sounds like it's going to be some nice, elegant answer.
Yeah, so you already got it. You said it right there in the middle. I couldn't resist hearing your thoughts on a couple other things. So sort of putting the case together in some ways, just looking, is there overlap, right, between the findings on the echo, which may just be incidental, right? You barked up a tree you didn't want to bark up, and then like retinitis, which I think is kind of what we're calling like the primary problem. And syphilis, so tertiary syphilis, can cause, of course, like, cardiac involvement. And then it also can cause, at any point, you can get ocular syphilis, right? You can get at any point, generally not right away. You're talking years into the illness, but it need not be a specific time frame. And so he gets the treponemal antibody comes back positive, and then that's followed up with the RPR, which is positive at 1 to 512.
Oh my
So he's
gosh.
he's considered to it's considered to be syphilis, acute syphilis, or excuse me, not acute syphilis, like late syphilis, which is treated with IV penicillin. Actually, like he's treated for neurosyphilis. He was planning to get an LP, but by the time we kind of got to do the LP, like went to do the LP, he'd already had like a fair amount of penicillin. ID said it wouldn't really change management based on what we found in there. I mean, it would confirm things possibly, which might be nice, but he was already improving on the IV penicillin. Um, and so, yeah. Now, do I know for sure that the findings in the heart were related to syphilis? No. I mean, we can't prove that. And who knows? Did this guy have non-ischemic cardiomyopathy for like almost a decade because of syphilis that was untreated? Like, again, I can't say for sure. But it was pretty severe, and the lack of any ischemia was surprising. There's also no regional wall motion issues. It was kind of global. So, I that was sort of how we got there to some degree. And yeah, so you said that. I mean, you brought up syphilis when you were talking about retinitis in terms of infections, and that's exactly right. I'm going to ask what your reflections are on the case, and then see if there's. I'll probably give a little bit of teaching here, but I wanted to hear your thoughts first.
Yeah. Yeah. I mean, I think kind of the clue toward it, if you were just like lost like I was, I think the clue still was in those weird antibodies because there was really no fit in terms of the clinical presentation and those auto antibodies. So again, whenever you see kind of multiple auto antibodies being positive, you have to ask the question, is there something driving that in terms of a chronic infection or a chronic malignancy that's causing that? And yeah, syphilis can totally do that. I've seen it on so many morning reports. But no, I think how you frame the problem ultimately is the most helpful for guiding probably the workup for this guy. Because I mean, at the end there, you asked me like connecting the heart, connecting the blood vessels in the eye. I think at the end of the day, that just confused me more than it helped me. The primary issue here really was like the retinitis. So if you just run that differential diagnosis for the infections, like I said, then yeah, it's on the list. Yeah, it is on the list. You just send it and then it falls right into your lap. And then you can kind of put the pieces together kind of in retrospect after that. And no, I feel like the aortic root dilatation maybe could have been related. We do know that syphilis can cause aortitis in like the tertiary phase, but also he's like an old guy, so you're allowed to have a little bit of aortic root dilatation at that age. And yeah, I totally wouldn't rule out that there are like spirochetes in the myocardium. Why not? We already know this has probably been going on for some time. So very, very cool case, Mike. Very excited we can finally get a syphilis page up on the website because we all know that we've been fooled by this. And yeah, I'm on that list today.
Awesome, awesome. No, yeah, you got it. So I wanted to give a little bit of teaching on sort of a couple things here. I think the first is kind of ocular syphilis itself. So this is sort of a bit more atypical. It tends to be uveitis is kind of the most common ocular presentation. What is different about this uveitis than any other is that most uveitis is painful, but generally it's painless with ocular syphilis. So anytime you like hear about uveitis and the patient didn't have kind of classic symptoms of it, then syphilis can should raise that specter. Um, and the other thing is that it's the color vision loss is seen fairly frequently when it is the retinitis for whatever reason. And the other thing is that it often does improve with steroids. And so I do think that was kind of that initial, improvement and then worsening again. It's exactly like you said, Andrew, that, kind of just in general, infections may improve slightly and then worsen again with immunosuppression, because the symptoms are related to the inflammation, not necessarily the actual organism itself. So I thought that was kind of very cool. Additionally, ocular syphilis can present kind of at any time, but it's in the tertiary period of time. So you wouldn't see this kind of right away. It is sort of in the middle, right? So like tertiary syphilis, you can see it from like 2 to 50 years. And it would fall sort of like not quite in the late neurosyphilis. It's a little bit kind of earlier in course, but we're still talking like years after. And the clue with this guy also was um, had been married for a long time, but there was some infidelity like 20 years ago. One time, which was probably what this was, and that was probably the last exposure from what we can tell. So yeah, I think that's sort of interesting. So, in terms of tertiary, right, the guma, the cardiovascular syphilis, the ocular syphilis, otic syphilis, right, hearing loss, all of those things. And when you see one, you want to ask about the others as well. And then of course, like there's meningitis and tabes dorsalis, which I think we think more often of. I think that's right. We tend to think of those things more commonly, but these other things are also presentations of tertiary syphilis. Um, and it's important because if it was just latent syphilis, right, you treat that differently than if it's like active neurosyphilis in terms of what you're doing with the penicillin, right? How long you're treating every day infusions versus just 3 times. Um, so this are sort of the big things, cardiovascular syphilis, really hard to make the diagnosis because you need a biopsy and then you need to use special microscopy, right? But it's relatively rare. It is myocarditis mediated. And the issue is that oftentimes it's not recognized, and then it does create, irreversible damage. And so I just wonder if, 20 years ago there was this exposure and he develops it, and then kind of 10 years later has this profound cardiomyopathy without a clear cause. So I don't know. I mean, it could be completely unrelated, but I just, at the very least, I had to learn about it to understand. And of course, right, like aortic aneurysms, valvular destruction, just AR from the root dilating so much. These are all, we learn that. I think we learn aortitis more often than we learn the actual myocarditis itself when we're studying for these boards and stuff. So yeah, those are sort
Wow.
of the things I wanted to share with you. And then, oh, the other thing that
Yeah.
was interesting is that, so you're absolutely right. Syphilis is one of kind of like the great mimickers for a lot of reasons. One of them is that it creates like this, to use your words, autoantibody craze. So very common. One of the things that's interesting is it will often, right, give you a false positive for like the lupus anticoagulant tests, right? But it's almost always beta 2 glycoprotein negative. So for some whatever reason, it doesn't affect that one. So this guy did have anticardiolipin that was positive, but then beta 2 glycoprotein negative. Again, like who knows? But I thought that was interesting. It fit. And then ANA positive, double-stranded DNA, and anti-RNP are much less common, but all have been documented. And then, of course, you mentioned the rheumatoid factor as kind of a non-specific clue, which was positive in this case as well. And what's interesting is that all of these things were then tested again after treatment, and they all resolved. So you had no auto antibodies like 12 weeks later when they were tested again, and you could see as RPR it also. I don't think it was zero, but it was pretty close. It was like you know almost gone. So
Wow.
very satisfying in that
Wow.
regard.
That's so
Yeah.
satisfying, man. Great work. I'm so happy for you guys. You got this guy an answer. Maybe even we'll have some reversal of his cardiomyopathy down the road. Goodness, that's one for the books. We have our GCA episode, and now we have our GCA mimicker episode. Jeffrey Shen, who his episode, I don't know what order it's going to come out in, but he has like a list of GCA mimickers, and syphilis is one of them. So we've officially crossed one of those off that list now. So Mike, final question for you. So because I really just want to understand like what the ophthalmologists were like seeing on that exam. So was that essentially just like small teeny vessel kind of vasculitis from the treponemes, and then they were just kind of exploding and they were seeing hemorrhages? I'm just like so curious what they saw because they were really struck by it.
Yeah, I mean, I had a hard time getting like an answer, and their notes are essentially not written in English at this point. So, that's right, Blood and Thunder, that's about all I remember. But yeah, it was like this kind of like central pallor, but then with like this like inflammatory signature on top of it that kind of had evolved over like 1 week that really just like sounded like they were excuse me, they were concerned about just retinitis writ large. And so, asked for really almost like an ophthalmology admission. But what was interesting about the case is that, had we not treated syphilis, it could have progressed to other manifestations as well. In addition to him not, losing his vision did resolve, or excuse me, his vision loss did resolve, and it was very cool. Like each day, we would bring in like these like color cards, and he'd be able to see the colors like a little bit better.
Oh,
And
it's so
he
cool.
gained all his color vision back, and then actually,
Wow.
I checked in on the chart. It doesn't look like he had any permanent vision loss. So yeah, it's kind of cool. He's had another heart failure exacerbation since then, so I don't know that it did anything for the heart. It's probably irreversible damage, if it even was the syphilis, right?
Wow.
But at least he didn't lose his vision.
Wow. How cool is our job, folks? Thanks, Mike, for bringing this case. Always a crowd pleaser.
Thanks so much, Andrew. Great work.
See you guys.
Take care. This has been Diagnostic Atypia with doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.